Welcome back to another episode of HealthCap Weekly Wrap. This week, we're diving into 5 powerful stories that touch on everything from sepsis care and infection control to PPE failures and vaccine gaps, all with a direct impact on the day-to-day lives of residents and staff in senior living communities.
Yeah, and what's great about this lineup is that we've got a mix of innovation, policy updates, and even some frontline realities that don't always get the spotlight. So, whether you're running a building or providing hands on care, there's a takeaway in here for you.
Let's kick things off with a story that could be a game changer for long-term care teams, especially when it comes to early intervention. This comes from Skilled Nursing News, and it's called The Sepsis Solution: How Telemedicine Transforms Sepsis Care in Long-Term Facilities.
Right off the bat, sepsis is one of the leading causes of hospitalization and death in older adults. And in many senior living communities, the big challenge is catching it early before it escalates.
Exactly. What this article highlights is how telemedicine, especially after hours, is helping teams do just that. Traditionally, if a nurse notices something's off at 10 p.m., they might have to call the on-call physician, wait for a callback, or worse, send the resident to the ER as a precaution.
But with telemedicine, you can have a licensed provider assess the resident virtually within minutes. They can guide the team through a full sepsis protocol, order labs if needed, or start antibiotics right then and there. No waiting, no transfers unless absolutely necessary.
And here's the thing. Not only does this lead to better clinical outcomes, but it also improves resident dignity and emotional well-being. A trip to the hospital is stressful, especially for those living with dementia.
The article even shared examples of communities that saw a reduction in unnecessary hospitalizations just by adding telemedicine to their emergency response workflow. It's not just about convenience. It's about targeted, high-quality care when it matters most.
So, if you're an administrator or clinical director, this is something to seriously consider. Ask yourself, are your after-hours protocols helping you catch sepsis early? And is your team empowered with the tools to make time-sensitive decisions?
Because every hour counts. And with the growing pressure to reduce hospital readmissions, telemedicine is moving from nice to have to need to have.
All right, let's zoom out for a second and look at the bigger infection prevention picture. The next article, from Infection Control and Hospital Epidemiology, is a comprehensive one. It's called Multisociety Guidance for Infection Prevention and Control in Nursing Homes.
This is a collaboration between several heavy-hitting organizations: SHEA, APIC, IDSA, and the American Geriatric Society, just to name a few. And while this came out a little earlier, it's still the most current multi-society guidance we've got that's tailored specifically for nursing homes and senior living.
And it's important to say this isn't just a rehash of hospital protocols. It's written with our environment in mind. It addresses the daily realities of congregate living, staffing challenges, and the complex needs of older adults.
One thing I really appreciated is the emphasis on empowering infection preventionists. So many of our listeners are either in that role or supporting it. And the guidance calls for more structured training, better integration with leadership, and giving IPC professionals a real voice at the table.
It also puts a big focus on preventing the spread of multi-drug-resistant organisms, MDROs, which we know are a growing concern in our communities. That includes MRSA, CRE, C. diff, and now more recently, C. auris.
The guidance stresses surveillance, hand hygiene, environmental cleaning, and strong antibiotic stewardship, which, let's face it, can be hard to maintain consistently. But the recommendations are practical and designed for long-term care realities, not just acute care settings.
So, what's the takeaway for our listeners? Whether you're a DON, an administrator, or a frontline team lead, your infection prevention plan needs to go beyond compliance. It needs to be dynamic, proactive, and most importantly, community-wide.
If your IPC program is still using old templates from pre-COVID days, this is a wake-up call. Pull the new guidance, walk through it with your team, and start prioritizing the changes that make sense for your community.
Okay, now let's get into something a little less clinical, but no less important: PPE. And more specifically, the experience staff are having with disposable isolation gowns. This article is from Biomedical Instrumentation and Technology, and it's titled Clinical Experience with Disposable Isolation Gown Selection, Strike-Through, and Reporting.
This one opened my eyes. It's based on a survey of over 200 healthcare workers, and the headline is this: more than a third of respondents had experienced fluid strike through while wearing disposable gowns. That means their clothing or skin got wet while delivering care.
And that's not just uncomfortable. It's potentially dangerous. It compromises both staff safety and resident protection. But here's the kicker. Nearly half of those workers never reported it.
Some didn't think it was serious enough, others didn't know how to report it, and some just assumed all gowns had this issue, so they didn't see the point.
The study also found that most workers didn't have a choice in the level of gown protection, which, if you're not familiar, ranges from level 1 to level 4 based on fluid resistance. So someone providing wound care or dealing with bodily fluids might be wearing a level 1 gown when they actually need a level 3.
That's a systems issue. Procurement decisions, staff education, and culture all play a role here. If workers aren't trained on gown performance levels or don't feel comfortable reporting equipment failures, gaps will happen and infection risk goes up.
So if you're in charge of ordering PPE or overseeing infection control, take this as an opportunity to review your current gown stock. Are you matching gown type to the care being delivered? And is your team trained to speak up when something doesn't work?
And maybe more importantly, do they feel heard when they do speak up?
This is one of those quiet risk factors that flies under the radar until something goes wrong. Let's fix it before that happens.
Speaking of infection risks, let's talk about Candidozyma auris, or C. auris. You may know it by its previous name, Candida auris. This fungus has made headlines over the past few years for being highly resistant to antifungals and easily spread in healthcare environments.
The next article from Open Forum Infectious Diseases is a clinical study titled Nasal Iodophor to Reduce Candidozyma auris nasal carriage in Nursing Home Residents.
Now, to be clear, this was a small study, just 10 residents in a long-term care setting, but the results are worth paying attention to. Researchers applied a 5-day nasal iodophor treatment, basically an antiseptic rinse, twice daily to see if it could reduce nasal colonization.
And in about half the participants, there was a significant drop in the amount of C. auris present in the nose. A couple residents even tested completely negative after treatment.
That's huge because if we can reduce colonization, we can reduce spread. And that's the holy grail when it comes to controlling C. auris outbreaks.
Of course, this isn't ready for prime time. It's early data and will need larger trials. But it's a promising step towards something we've been missing: a way to decolonize residents without relying solely on environmental cleaning and contact precautions.
So, for our listeners in infection prevention or clinical leadership, keep this on your radar. C. auris isn't going away, and any tool that helps us manage it better is worth watching.
All right, let's end today's episode with a simpler but incredibly important public health reminder. This one comes from the CDC, a short guide titled Diabetes and Hepatitis B Vaccination.
Now, you might be wondering what the connection is. Here's the deal: adults with diabetes, especially those over age 60, are at higher risk of hepatitis B. That's because they may need frequent blood glucose testing, finger sticks, or injections, which increases the potential for exposure to bloodborne viruses.
And in senior living communities, that risk is compounded when residents share devices or supplies, or when staff aren't following proper infection control procedures.
The CDC recommends that all unvaccinated adults with diabetes under age 60 get vaccinated for hepatitis B. For those 60 and older, vaccination is still recommended based on risk factors and exposure potential, which in a senior living community is often present.
So what can you do? First, check your records. Are your diabetic residents vaccinated? If not, talk to your medical director about starting a catch-up campaign.
And second, staff education. Make sure your team knows how hepatitis B spreads and how to prevent it, not just for residents, but for themselves.
All right, that wraps up this week's stories. We talked about the rise of telemedicine in sepsis care, the latest infection prevention guidance, real-life challenges with PPE, new research on C. auris, and a critical vaccination reminder for residents with diabetes.
Thanks for tuning in. We hope you're walking away with ideas, questions, and maybe even a few action items for your team. If you'd like to read the full articles or explore more, head over to Angie's blog at healthcapusa.com/Angie's-blog. Until next time, take care, and thank you for everything you do to support and care for our residents.